This meeting is being recorded.
Oh, we're being recorded, so you all better watch your P's and Q's, okay? Tonight we're really fortunate. Once again, I think we've gotten very lucky. We have an outstanding group of people who collaborate in a unique space in surgery. As a transplant surgeon, growing up, I used to always tell people that, when they would ask me why I did transplant surgery, well, it's because transplant surgery is the only discipline that changes the natural history of disease. Well, through the years, and I would say that certainly in the last 10 to 15 years, I've learned that there's probably another group that probably does it better. And I think it's definitely the bariatric group and the things they're doing with bariatric surgery to affect disease. And as we're moving into, we've gone through, enhanced recovery protocols. We're really trying to push the envelope, not trying, but I think we have pushed the envelope with same day surgeries. And certainly, 24, it was crazy when we were doing the 24-hour nephrectomies, donor nephrectomies. People thought we were nuts. And now we're doing them all same day surgery in most places. And tonight we're actually honored to have Tina Barani, who actually won the best paper last year for this presentation. And they have subsequently been published in the Journal of the American College of Surgeons. And tonight we're going to hear their presentation on the safety of same-day discharge after bariatric surgery. We have Dr. Shu with us, Dr. Sai, Dr. Barani, of course, and shortly, hopefully, Dr. Tavakoli. And with that, we will hand the rein over to Dr. Shu, who will initiate the continuum of this presentation.
Thank you, Carlos. Thanks for having us. Really a pleasure to share our work here. I was just going to introduce Tina Barani, who did the hard work here, and let her present the data, but wanted to give Tina an adequate introduction. She's a chief resident currently at Thomas Jefferson in Philadelphia, and she wisely has chosen to a career in MIS and bariatrics. She's going to be the fellow at the University of Iowa next year. Tina and I met and worked on this project a couple of years back when she was at the Brigham doing a year as a nutrition fellow, and her spare time was remarkably productive in research. Just to sort of set the stage, this was around 2022. We were coming out of COVID. Bariatric surgery in particular had been delayed, and there were lots of issues, at least on our end, with staffing, hospital availability. We had really implemented ERAS programs, as you'll hear later on. We were sort of ramping up in our home hospital program, and a lot of folks around the country, probably people in this room, had sort of started exploring same-day discharge for bariatric operations, particularly in light of sort of the hospital bed issues with COVID. So Tina was interested in learning what we could in terms of whether this was a good idea in terms of safety or not. So I'll turn it over to Tina.
Thank you so much, Dr. Shu. I'll share my slides. Dr. Shu spoke briefly about what was the motivation for our study. So some of the points before we dive into the methods. Less than 1% of eligible patients are currently undergoing bariatric surgery. The waiting time for bariatric surgery has doubled in the past decade, especially for those who are on Medicaid insurance. Additionally, during the COVID-19 pandemic, we saw that there was a decline in bariatric surgery given its elective nature. Therefore, the minimally invasive approach that resulted in decreased post-op pain as well as increased utilization of ERAS protocols led to the reduced length of stay that was seen for bariatric surgery during this period. To further reduce the hospital resource utilization and thereby increase the volume of bariatric surgery, there has been increasing interest in same-day discharge after bariatric surgery. Moreover, the insurances are attempting to remove sleeve gastrectomy and gastric bypass from inpatient lists only, thereby increasing the pressure to perform these procedures in an outpatient setting, which could lead to significant impact on reimbursements for patients who require hospital admission. Therefore, our study aimed at analyzing the trends in same-day discharge, preoperative factors associated with increased complications in same-day discharge cohorts, as well as perform a comparative safety of same-day discharge and admission cohorts. We utilized the MBSA-QIP database from 2016 to 2021, and we selected for patients who were undergoing primary laparoscopic or robotic sleeve gastrectomies or gastric bypass. Same-day discharge was defined as discharge on the day of surgery, and admission was defined as discharge on post-op day 1 to 30 after surgery. Multivariate regression was performed on preoperative patient characteristics that were predictive of increased complications post-op. This was followed by a comparative analysis of post-operative outcomes within 30 days for same-day discharge and admission cohorts after one-to-one nearest neighbor propensity score matching for patient demographics and comorbidities. We saw that there has been a rising trend in the utilization of bariatric surgery from 2016 to 2021 in the MBSA-QIP database. Specifically, the overall rate has gone up from around 2.5% to 7.4% in the 6 years. And a rapid rise has been seen for same-day discharge in sleeve gastrectomies, where it was around 3% in 2016, which then doubled to almost 6% in 2020 to almost 10% in 2021. The risk of major complications declined over the years, specifically for gastric bypass had gone down from 4.3% at its peak in 2017 to almost 2.4% in 2020, and for sleeve gastrectomies from around 1.3% to about 1%. There was also a significant decline in readmissions among the same-day discharge cohorts, specifically for gastric bypass from 7% down to 4.3% over the 6 years, and for sleeve gastrectomy from 2.7% down to 1.8%. Among the preoperative factors that were associated with perioperative complications for same-day discharge, we saw that increasing age and male sex were protective against the complications, while the African American or Black race population had higher risk of complications after same-day discharge. Gastric bypass had 72% higher risk of complications compared to sleeve gastrectomy patients who underwent same-day discharge. And among the comorbidities, GERD, history of MI, DVTs requiring therapy, renal insufficiency had almost double the risk of complications, patients who were currently smoking. History of sleep apnea, history of PE, and diabetes were also associated with significant risk of complications post-op. After matching, the post-operative outcomes in the match cohorts that had higher risk included cardiac arrest requiring CPR, which was almost 3 times the risk in patients who underwent same-day discharge. The same-day discharge cohort had 33% higher risk of dehydration requiring IV treatment and double the risk of mortality within 30 days. Other outcomes that were better in same-day discharge cohort included C. diff infection, unplanned ICU admission, readmissions, reoperations within 30 days, and major complications. The major complication cohort included a pool analysis of readmissions, reoperations, ED visits, reinterventions, cardiac arrest, MIs, as well as mortality. And I think this rate being lower was probably driven by some of these other outcomes that were significantly lower in same-day discharge cohorts. The outcomes that did not have a significant difference between the two cohorts included renal failure, MI, stroke, surgical site infections, prolonged ventilation, reinterventions, and unplanned intubation. Therefore, in conclusion, we saw that there was an increase in same-day discharge after bariatric surgery over the past 6 years. There has been a decline in major complications for same-day discharge. However, we cannot ignore the fact that the mortality rate is double in the same-day discharge cohort as compared to the admission cohort over the past 6 years, as evidenced by MBSAQIP database. Additionally, the risk of complications is higher for gastric bypass as compared to sleeve gastrectomy cohort. Therefore, the current data does not support the safety of these bariatric procedures as outpatient procedures. And we need to further look into selecting eligible patients who are healthier at baseline, who would be better suited for same-day discharge, as well as look into alternative approaches that will improve the outpatient follow-up of these patients, such as home hospitals. At this point, I will hand over to Dr. Sai to speak more about the home hospitals that he has been working on for a long time.
Great. Thanks so much, Tina, and great to be with everyone. When I told my wife that I was doing an intellectual happy hour, she assumed I was going to a bar. So I hope all the folks off camera are nursing a beer right now. But great to be with all of y'all. I'm just going to share a little bit about some of the work that we're doing with the home hospital program, specifically around bariatric surgery, and give highlights of how we set up our randomized control trial and a bit of the rationale for doing it as an RCT versus just a implementation of a new care model, and then talk a little bit about some of the more recent data that come from colleagues overseas on their experience with the home hospital program. But just as a bit of background, and Tina alluded to this, home hospital has been around for several decades, especially among our medical colleagues. So especially in Australia, in Spain, and then some centers in the US, like at Hopkins and Mount Sinai, have been long-standing innovators and adopters of the home hospital model. And the idea isn't just discharging patients to home early with home services, but is actually providing the same comparable level of acute care services that they would be receiving in the hospital, but minimizing the risk of healthcare-associated infections and sort of what some people call an acute hospitalization syndrome. But the issue for scaling has always been that there hasn't been a reimbursement model for it, because in order to provide those services, whether it's extra staffing or remote patient monitoring, requires a lot of investment, effort, and was not reimbursable. And that has been a limitation, unlike for other countries in the US, for scaling that model more broadly, and especially to surgery. However, as Tina mentioned, with some of the capacity concerns during the pandemic, the stars aligned, and CMS in November 2020 initiated the acute hospital care at home waiver, which they had launched in an announcement for their Hospital Without Walls program. And that, for the first time, actually allowed reimbursement at inpatient DRG levels. So you could provide home hospital care, but the hospital would still be reimbursed as if the patient was admitted to the hospital, which had unlocked not just the capacity to invest and pay for this model, but also potentially capture extra margin as the care at home could be potentially more efficient than if they took up a hospital bed. However, that was contingent upon actually providing hospital level care. So the CMS had requirements around screening protocols, where the patients could be admitted. They needed to have a physician evaluation, and really needed to be inpatient level care and not just outpatient surgery. After the waiver flexibility ended after the public health emergency ended in May of last year, but as part of the appropriations funding, they increased the waiver for another year, but there is no permanent funding or regulation that allows for this to continue. And actually a lot of ongoing advocacy right now among many physician societies and acute hospital home interest groups for Congress to continue this waiver. And when the time this program launched, we had written, this is here on the right, a perspective in JAMA Surgery, highlighting the program and the relevance for surgery, but then also some potential quality metrics to consider as patients transition from phases of care in the home hospital model. How we had initially implemented this at the Brigham, and it's evolved sort of as the program is scaled beyond Brigham to MGB, is we really tried to replicate truly an inpatient level of experience. So there'd be patients undergoing home hospital care would have the exact same experience as they would if they were admitted to the hospital. So this included twice daily nurse and medic visits, so comparable to, sort of the nursing shift evaluations while they were in the hospital. There was a daily physician visit. At the Brigham was initially performed in person by hospitalists, but the patients would still remain under the surgical service, the surgical team still rounding virtually, but responding, communicating with the home hospitalist physician team, who were the responding clinicians, to deal with more immediate pages and orders that needed to be written. They were able to receive IV medications. They could receive advanced respiratory treatments, CPAP, nebulizers. There was a full remote patient monitoring system with basically 24/7 telemetry, so it's even a higher level of monitoring than they were receiving on the inpatient arm. Availability for diagnostic testing, so labs could be drawn and sent to the labs. More recently, they've been updated to include point of care iStat testing, as well as 24/7 phone and video virtual care, including the availability for virtual consultations as well for endocrinology, for management of diabetes, for dietitian or other services as well. So again, because it was uncertain with this new model if this was actually going to result in better outcomes for patients, we launched our program at the Brigham with the support of Dr. Tavakoli, Dr. Hsu, the rest of the division, and the department and hospital overall, as an RCT, randomizing our patients undergoing bariatric surgery, initially sleeve gastrectomy, to home hospital versus standard of care, which was already our enhanced recovery protocol on the inpatient setting. Because the complication rates are generally pretty low, we focused on outcomes that were both focused on value as well as patient experience. So the bed days that were saved in the hospital from the perspective of the hospital, and patient experience from a validated PROMS measure called BodyQ, including the satisfaction with their experience with the information received, with the surgeons and doctors and the overall medical team. If there was ED presentation or admission within 30 days, including escalation of care, so while they were still admitted to the home hospital, were they transferred back into the inpatient physical hospital, the overall cost during the episode, as well as the morphine milligram equivalents or MMEs, with hypothesis that there would be faster recovery and less need for opioids and narcotics. So I won't sort of go through the whole algorithm of how we set it up. It took over a year and lots of stakeholder groups across anesthesia and surgeons and our inpatient, outpatient PAs, our residents, to work out sort of the optimal flow. But we really wanted to replicate the same experience they would have in the hospital. So patients basically would undergo surgery, be in the PACU for about 3 hours. If they met sort of transfer criteria to the floor, a very comparable set of transfer criteria, that could be transferred, not discharged, but transferred to the home hospital program. So we're doing direct surgery to PACU, PACU to home, which I think is a key differentiation between some programs which are transferring the patients to home hospital after being in the hospital for a day or two. So I'll skip through this. Happy to go into a little bit more detail. The way it was actually implemented at the Brigham is that the home hospital, because the patients are still in inpatient status, it's an actual floor of the hospital with a virtual floor. So basically as if the patients were boarding at home. The same documentation and Epic, the same order entry. So patients look as if they are admitted to the inpatient status. We included a full suite of real-time wireless monitoring, including at the time a vital patch system that measured EKGs, respiratory rates, temperature, accelerometers, including a number of steps. So that was a secondary outcome measure, is how many steps the patients took in the home hospital program versus the control arm. We had a wireless blood pressure cuff, a wireless pulse oximeter. So really all of the vital sign monitoring capabilities were available at home as we were in the hospital. And then on the clinician side, we actually had this on the app, the Bioformus platform, where you could real-time see the telemetry strip, the heart rate, respiratory rates, We had on the right a checklist to communicate tasks. This is a medical patient, not a surgical patient, for the screenshot to the home hospitalist team to be able to communicate, sort of the workflow for the patients. So a really seamless integration of the patient monitoring system with the workflow and with Epic. So the RCT is still underway, and in the interim year, the program has scaled through MGB, which has created a whole hospital level division called Healthcare at Home, with the vision of scaling the home hospital program across medical and surgical conditions across all the academic medical centers at MGB, as well as the community hospitals within the healthcare system. And in the interim, there's been sort of modifications to the implementation. We've updated moved away from the Bioformis platform and use a new remote patient monitoring platform called Current Health. And then right now, there's been a pause on the RCT from system leadership as there's been a system level goal of really trying to ramp up the average daily census in the home hospital program. But so our trial was enrolling, but is currently paused. So we can talk a little bit about sort of the anecdotal experience. We haven't done the interim analysis yet. That's a decision we were trying to make about sort of breaking the protocol and just doing the interim analysis now versus continuing enrollment. In light of the operational imperatives of the system more broadly. But I wanted to share some evidence from the literature. The surgical colleagues from the hospital clinic in Barcelona recently published a case series of their experience with home hospital in Barcelona, and this was in the Annals of Surgery of this year. I only pulled out the bariatric patients from the study relevant to the study that Tina presented. But to Carlos's sort of point, this is applicable across multiple surgical specialties. In fact, in Barcelona, they also have this program for post-kidney transplant patients as well to provide hospital level care for patients at home. But this is their protocol, at least in terms of the patient flow. They transfer the patients to the home hospital on day one. And then they're only really in the home hospital program for a day and then discharge on day 2. I think one thing to highlight is that for most of us, our average, lengths of stays are a day or less anyway, for bariatric surgery. So, there are sort of variations in, what the appropriate utilization of a home hospital would be during the inpatient length of stay. But just jumping ahead to the outcomes from their study. So they had 141 patients. Again, this is just a case series, no control arm. And they had about 60% bariatric bypass patients versus 40% sleeve gastrectomy. And no escalations of care. So during the 2 days that patients were in home hospital, none were transferred back to the hospital. However, 11% ED visit rate at 30 days, a 2.8% readmission rate, which is actually pretty comparable to the MBSA QIP data that Tina showed. But I think also worth highlighting what the complications are. Out of those 4 that were readmitted, 2 were hematomas. 1 was a surgical site infection abscess, and 1 was eventration. No further details were prescribed. Not sure if that was dehiscence. I hope it was not evisceration through a laparoscopic port site. But 3 of these patients required surgical reoperation or reintervention. So again, none of these actually occurred while they were in the home hospital program. But the question is, would they have been recognized potentially if they were in the hospital versus at home, and could some of this cascading of complications be potentially prevented? So I think the devil is really in the details about how the program's implemented, the right type of surgical patients. And then a big difference, I think, in my conversations with medical colleague is, our complications are different. We have rare, infrequent complications, but that are catastrophic. Whereas, for medical patients with UTIs or pneumonia, they have a higher rate of sort of complications, but at a lower acuity. So the thresholds for rescuing failure, I think, is quite different in the medical versus surgical home hospital models. So I think important to kind of be thoughtful about that as we as these models scale across the country. So stop there. Happy to answer any questions, but I know Dr. DeMaria was also going to discuss what Tina had presented.
Right. So, again, along we've initiated a very nice tradition. I think we've had some amazing people participate as discussant, and once again, we're very honored to have, what I would say is one of the preeminent authorities in bariatric surgery, and the immediate past president of the American Society of Metabolic and Bariatric Surgery, and my current chairman. And I feel very lucky to say that. And Dr. DiMaria, thoughts and comments?
Yeah, thank you. Thank you, Carlos. I enjoyed both presentations. Really nice work, and congratulations. I thought we had referenced before that there are multiple single institution studies looking at this question. And so I thought I would relate just briefly our own experience at East Carolina University, where we began our same-day discharge program for sleeve only back in 2019. Fortunately, that was before the pandemic. And so we already had baseline data before we ever had to deal with that delay in elective surgery. But it's interesting to me, and I'm going to frame this as a question, I think, for Tina, but it looked like, I would characterize this paper as a real world experience, right? I mean, there's no protocol, there's no inclusion criteria. You're just trying to figure out what people have done. And yet our approach was very controlled, in that we selected low acuity patients for same-day discharge. I wonder, have you done a subset analysis where you've excluded the factors that you identify as high risk factors, things that wouldn't qualify in our program where we've had excellent outcomes? Now about 25% of our patients are same-day discharge, and never a mortality, for example, in that group. And that goes back 5 years. But I'm curious if you excluded the ones with MIs and previous venous thrombosis and renal insufficiency, things that we wouldn't have allowed to be same-day discharge. What do the results look like then? In other words, is there a subpopulation where this can be done safely?
Thank you, Dr. DiMaria. That's an excellent thought. We haven't done the analysis yet by excluding those high-risk populations who you wouldn't discharge in the real world in our practices, but I will definitely look into it to see how the outcomes are improving.
Yeah, I think it might be interesting. I mean, it's still valuable to know what the MBS-AQIP population is doing, and certainly I think caution is advised based on the outcomes of the data that's reported in MBS-AQIP. But I thought I'd maybe fuel the discussion a little bit by talking about financial incentives briefly. There's a lot of parts of the country where, for example, at our place, it doesn't matter to us if we do the case in our main OR or across the street at our ambulatory OR. We have no individual financial incentive. My understanding is in Texas and some other states, the idea of surgeons owning their own surgery centers is rampant. And so there enters into the equation a potential conflict in terms of the financial reward for doing these cases, hospital-based versus your own outpatient facility. And I think that confuses the issues, which is why it's nice to have a study that says there are factors that are high risk, and those patients need to be avoided in the outpatient same-day discharge setting. So love to hear some comments on how your environment works. I would imagine you all don't have much financial incentive to move to a same-day discharge necessarily.
I see. My boss came off mute, so I was going to give Ali a chance to respond
No,
there.
no, no. I'll go. I'll make silly comments later. You go. You make the smart comments.
No, no, but I was gonna say you're absolutely right, Eric. It's the facility fees. I mean, for the professional fees are the same. You know, regardless whether you do a day surgery or not, or right, it's just a CPT code. But the facility fee, share, becomes the devil's in the details, and I think there's definitely, I think, a small but observable growth in the proportion of outpatient sleeves, especially being performed at physician-owned ambulatory surgical centers. Actually, of which in Medicare, 90% of ASCs are actually owned by physicians anyway. So you get to keep both the professional fee and the facility fee, which is not insignificant. So there's definitely is a financial incentive there. What's interesting is actually for healthcare systems, they have been, the shift was in the opposite direction, because the healthcare systems were buying up ASCs and then billing them as hospital outpatient departments, because they could get about twice the facility payment for a hospital outpatient department, versus a ASC, even though it all, it looks like a duck, it quacks like a duck. It's an ASC, but if they were billing as a hospital, the facility fee payments are quite different. So on the Medicare policy side, there has been a big push to move towards site neutral payments to equalize the facility fees. But now healthcare systems often are owning the practices anyway. So for them, as in our own healthcare system, they're not playing the site neutral game anymore. And if they can capture the revenue, whether it rolls up from the hospital to the enterprise or the physician group or ASC, it's still revenue for the overall healthcare system. So what we actually are seeing more common now is integrated healthcare systems are opening up their more and more ambulatory surgical centers, giving up on the facility fee payments, but trying to do a little bit more site of care optimization, because they're capturing revenue from the physician groups one way or the other. So it'd be interesting to see on the academic side if there's an equal pressure, not so much financial, because we're not revenue sharing, generally speaking, the facility payments, but more from a organizational leadership, sort of pressure to move towards outpatient, whether it's billed as hospital outpatient or ASC. So I think, again, sort of be interested to kind of see how, and I think it's going to vary quite a bit by the strategies of various healthcare systems and various markets.
And to just follow up with a further economic question, and I'll turn your own words against you a little bit. You said if it looks like a duck and quacks like a duck, it's probably a duck. The home hospital model you described sounds a lot like a hospital ward to me. And are you being reimbursed differently for those patients with that care? And what are your costs? Are your costs actually lower than running a hospital ward?
Yeah, so the payments from Medicare under the waiver, you being paid full freight, the full DRG payment, as if they were fully admitted as an inpatient. Now that's only under the waiver, and that's that becomes hugely, I won't say profitable, but there's definitely margin there. You are freeing up a bed, so it increases volume. But for other procedures, it's and still capturing the full DRG payment. So what's happened is, what's interesting is what the commercial payers are doing. So some are following Medicare, some are negotiating a reduction on their home hospital programs to say it's not real, you're doing all of the stuff, all the services for inpatient care, but it's not really taking up a bed. So they're negotiating like a discount off of the inpatient payment. And then there's also just outright denials. And I think that's the danger, is there are so many different versions of home hospital programs in terms of the intensity of care that's being provided. So it's very easy and for especially commercial payers to just deny the payment entirely. And I think there were actually issues with that within MGB. As well, with sort of other initial implementations of the home hospital program. So I think that's why there's been so much pressure on for Medicare to continue the waiver.
Interesting.
Any other questions? I'd imagine I'm always picking on my friend Dr. McEnany, but you know, he's one of the smart guys out there that really knows how to sort of negotiate these things, and I'm sure is working on them every day. What are your thoughts?
Yeah, Carlos, that's why my hospital is about, I don't know how many tens of millions in the hole. But thank you. Great job as always. I'd also like to say hi to Eric. It's great to see you again. Dave McEnany at your alma mater of BU and Boston Medical Center. It's great to hear about all the great things you've done. I'm thinking about this from the lens of our patient population at BMC and the number of patients we see who do not speak English. And I'm curious how this system works for same-day discharges or home hospital. Home hospital is another issue, but more of the same-day discharge, I suppose, as far as the education efforts. Does it change how you educate the patients? Is most of your educational effort really front-loaded with multiple visits over the years and months leading up to these operations? Does it compromise the education you give immediately post-op? And do you think that we can do a better job doing that? And how do you assess candidacy if patients don't speak English? Anyone? Tom, we'll go to you.
Yeah, I mean, for the home hospital program, the way MGB's implemented it, Spanish, it's non-native English speakers it's not or non-proficient English speakers. There's not a contraindication. So so we actually enroll a lot of Spanish patients, both on the medical side and the surgical side. But that's enabled by virtual sort of translation services. But again, that's expensive. Is it the same? But often, we're often using the same, whether in-person interpreters or the kind of video interpreters on iPads on wheels in the hospital as well. So there's definitely that. So it's doable, but again, it requires a lot of effort to make sure we do all the education up front. Again, and that's for all those reasons. That's why we wanted to randomize, to implement this in an RCT way. My specific population, I operate mostly out of Faulkner, and my catchment area is mostly Mass Health patients and largely Spanish speaking. So that is a front and center concern. But like with other programs, we've put a lot of thought in over the years on translating our nutrition handouts and our handbooks. One of our dietitians speaks Spanish and Portuguese, so we're trying to tailor a little bit of the preoperative experience and education for our patients. But again, that is a challenge. To your point about sort of BMC's population, in the national evaluation. So my colleagues and I published in Annals of IM the interim analysis of the Medicare waiver, so about 7,000 patients across the country, both medical and surgical, although mostly medical. About 14% of them were dual eligible, so Medicare and Medicaid patients. So again, a proof in principle that in some ways it is very feasible. In fact, in some ways even more preferable, because what we found anecdotally through qualitative studies is that it's actually sometimes a bit of the worries that it was kind of a luxury to be at home, right? To be, or rather to be in the hospital if you need to take time off of work, being at home requires a amount of social support. I mean, our program requires that you have a family member at home with you, right? So there are real equity gaps potentially between, whether patients can do day surgery, home hospital. A lot of my patients who are young moms actually want to be in the hospital. They're like, keep me in the hospital for as long as you can away from my kids. So that's actually been a challenge on the enrollment side. But you raise really, really important issues about the equity, and I think these are similar challenges across all three discharge pathways. And the key is how do we, to Eric's point about patient selection, it's also from a socio-demographic standpoint, how do we optimize for their, optimal sort of, social factors for the recovery?
Dr. Kelly.
Hey, thanks for this evening and the presentations and discussion. And Tom, I look forward to seeing you out here for our grand rounds next month, and subject matter that's dear to my heart about healthcare and some of the crisis and that's going on. And this is a different direction. And Eric, welcome to the discussion, and thanks, Tina, for yours presentation. My interest or questions focused around where does this go? I think you touched on a little bit. For me, academic medical center, where's my incentive? Meaning the hospital seems to have a win-win, and yet if I go to a surgery center, I don't have any incentive of going to another place right now. And number two, we have this battle lines being drawn here at Hospital at Home where they're not going to let the residents be part of the phone calls. Whether there are patients going home, the ACS patients going home, the consults that linger on the medical patient going home, we're going to be the ones. What's my incentive to discharge these people when I'm comfortable having, the residents kind of manage them, the quid pro quo, historical setup we have, and now they're going to go home, and mine and my team are going to get these calls. This is kind of a nightmare to me. I think that's to you, Tom.
Yeah, no, absolutely. And the way we implemented our trial, and that's why we partnered with our hospitalists as the responding clinicians, because they were doing like shifts. So, and they could still bill, their daily sort of roundings. So they're billing as consultants. So it's sort of win-win. They were willing to be sort of the responding clinicians. We would still be the attendings of record, round with them in the morning, albeit virtually. But then they had an incentive to take those calls because they were still, billing as a consultant. That's the way it was initially implemented. What MGB's moved towards is hiring advanced practice providers to sort of field all of those calls. But it is more work. From my colleagues on the call who have had home hospital patients, it is more work, not less work. Because there's potential that now the surgeon is sort of the first respondent for everything, and it's just may not be feasible for in the OR. We can't sort of hop on a virtual call with so how you implement that is I think really, really important, and how you train, right? If it's not, APPs aren't the answer, you also have to train them, right, in recognizing complications. And then there's a separate issue about the residents is that how are we training them if we are shifting a lot of post-operative management to outpatient surgery or either single discharge or home hospital. So how do we actually reintegrate the residents so they can practice sort of in the new way of managing patients post-operatively? So it's not just about what's most efficient for the healthcare system, which is largely what the healthcare system is focused on, but as a surgeon at a teaching hospital, as many of us are, how do we integrate the education and training component? And so the way we did it was really we tried to, the surgical team would still round virtually in the morning with the patients. And call them so they're still mimics what like AM rounds. You don't have to be at 6:30 anymore, but at least mimic morning rounds and do the same PM rounds. So it would just be done virtually. So that's how we had implemented the trial. Now, the systems goals are to scale. So there's a little bit of figuring out going on within MGB on sort of how to optimize for patient outcomes, but also sort of scale across a very, very different hospitals and very different cultures.
So did I catch that right, that you in your group, your hospitals also had kind of difficulty and pushback from kind of residents and program directors to have the management and phone calls go to them?
So we didn't have them go to the residents because it was we sort of had them round, but our responding clinicians were the home hospitalist, internal medicine hospitalists. Because it wasn't fair to do that. So Denise G and GH, initially she had her fellow sort of take the call. And it was almost like a moonlighting gig to do so, but but we navigating the complexities of ACGME rules around that were hard. So they weren't responding clinicians per se, but we still built it into the rounding sort of on post-op day one. But to your point, John, my first patient had a hematoma, had a bleed, and I was up all night dealing with it, right? So even though I wasn't the responding clinician, I was still the attending record. So like it was very, very much, like managing an ICU patient from home.
Yeah, I kind of foresee a union strategy in the future or some collective bargaining for surgeons. I think it's coming.
Dr. Tavakoli.
Thank you. So wonderful discussions, Tina. Nice presentation, and Dr. DeMaria, great to have you here. So Eric, I was surprised to hear you do 25% of your sleeves now as day surgery. So this is no home hospital, just day surgery.
Correct. Right.
So let me
Have been doing
ask,
for 5 years.
yeah, so let me ask about the financial implications of that. And because about 6 months ago, or maybe 9 months ago, in Massachusetts, there was a push to do sleeves only as day surgery. And that clearly has significant reimbursement implications for the hospital. And in fact, John Kelly, and hopefully he can comment on it more, he led an effort at the state level to stop that, to make sure sleeves are covered as an inpatient. But for you, if you're doing 25% sleeves as outpatient, how does the finances work for the hospital side? Is bariatrics still profitable? And the other concern for us was that if the hospital loses that profit margin, they will not support the programs that usually goes with a successful bariatric program, such as dietitians, psychiatrists, everyone else.
So the phenomenon I'm describing is same-day discharge. We do the cases in our main OR, and we have an ambulatory surgery unit where we discharge patients from that unit. We only do commercial pay patients there. The Medicare and Medicaid patients that we have follow the mandatory inpatient rule, which we learned the hard way. With Medicaid, we didn't necessarily expect that, but we discovered when we did a few outpatient Medicaid cases that we weren't paid. So we learned that they were following the CMS rules on inpatient stay. But the majority of our commercial pay patients now are done on a same-day discharge basis, and most of them go home the day of surgery.
And the hospital it gets reimbursed the same amount as if it was an inpatient stay.
Yes, and costs are lower, obviously, so margin has remained relatively intact for those patients.
Mm-hmm. Yeah, interesting, because this is what we were worried about and pushed against because I had always thought about, the Tina's paper was important because we were getting pushed to do day surgery. We didn't necessarily want to do day surgery. So the study shows it doesn't, so we don't do day surgery. We still have the push from the healthcare system to put empty beds. So we just do patients as home hospital. That's kind of how I had always thought about it. Although the more we've done of this, and I know Tom and I have discussed this, I'm less sure if sleeve gastrectomy is the home hospital, perfect home hospital, because they only have a one-night hospital stay at worst. They go home and you're done. So you go through a lot of education and infrastructure building to maybe save one hospital bed. And, I think the other areas such as, ileostomy reversal, colectomies, or other things may be more suitable procedures for home hospital than sleeves, but be interested to see what others think about that.
Yeah, and I just want to comment briefly on the mandatory inpatient stay. I am a proponent of that continuing. If you look at those populations, the government pay, Medicare, Medicaid, Medicare patients are primarily either older or disabled. That's not a good population for outpatient treatment. And Medicaid, we have the same challenges, I think, that I've heard you all talk about, which is, they don't speak English, or they have very disadvantaged socioeconomic system. We still have challenges with that population, trying to get them to understand how to take care of themselves immediately after surgery. is a definite challenge.
Ali, following up on what you said about the battle with the outpatient in Massachusetts. So, we were successful, but, the creep is going to continue and eventually I think we're going to lose. We've already lost a few in this state. I think Tufts is that, and, Blue Cross of Rhode Island, blah, blah, blah. There's a few others that are even local. Nationals do what the nationals do, but even our voice with the locals is going to get lost, I think, eventually. So the tactic is, and unfortunately, our provider relations don't necessarily want to do it, is they have to go and seek out the higher tier outpatient, what do you call it? Outpatient rates. Okay, we'll call it outpatient, not same day to me. Outpatient rates, like the hips and knees get. And that's what we have from some of them. But you'd be surprised, when you fall into general surgery, outpatient rates, and you're getting $4,000 to the facility. I mean, it's really, you lose your shirt, you have to close the restaurant, so that's what I'm discovering, is that I'm trying to push our, just backwards provider relations. They don't want to do carve outs. I know it's all about, these big contracts are too hard for us to understand, but that's where I kind of feel like I can't fight the fight anymore. It's just the creep is happening, and you just have to get a higher tier outpatient rates, and your program will survive. I mean, it's been broken since Medicare just has two. It'd be great if we had two rates, three rates rather, a short, outpatient, like same day, short stay, and then inpatient rates, but nobody's going to go probably, fight that battle to get, a 3-tier rate. So right now it's good.
And John, would that,
Yeah.
Determined by the physician, not by the payer? Because what we're in danger of here is losing the population that we can salvage from certain deaths from obesity and its complications, right?
Right.
The high-risk patient is going to become a thing of the past, and they have
Right.
no other alternatives.
Right. Everybody will turn them away.
Tina, can I ask a research question for you? So, in your database, the way you define same-day discharge, that's a defined variable on the NBSQIP database, correct?
No, it's not a defined variable. What we did was they have a variable for the day of discharge. We selected day 0 for being same day discharge, and post-operative day 1 was selected as admission cohort.
Okay.
So it might have been one of the gray areas where people who stay overnight may be counted as being discharged on post-op day 1, but will still classify under same day discharge / outpatient category in some hospital systems.
Because I think people play the game of they had a 23-hour stay, right? So it's not. So I guess your data, in theory, includes people who went home the same day, literally like the same calendar day, versus it could be people who actually stayed in the hospital overnight, but they went home less than 24 hours from the day of surgery. That could include that, right?
No, it wouldn't include that because post-operative day 0 was the calendar day of surgery in the
Okay.
database.
Okay.
So before midnight on the day of the procedure. And
Yes.
that's the way we look at it as well.
Thanks.
But congratulations to you guys for another little nuance, which is including in the admission group people who stayed in the hospital for 30 days. I didn't, until I read the paper, I didn't realize that groups were excluding those patients who had prolonged hospital stays. What a fake out that is, right? I mean, you go home on day, 2, fine, but if you had a complication, you're not going home on day 2. You're missing a whole bunch of complications that way.
Yeah, this is great work, and I'm struck by how much oftentimes we have a lot of conversations about sort of the fiduciary aspects of what we do, which is always, I always talk about it's all just funny money, because it's all sort of circular in nature and who's getting what and everything. And, and I think that's my way of making fun of things that I just, quite frankly, don't understand and don't want to understand. The part that really fascinates me, though, is if you think about this. So back in the late 90s, early 2000s, Northwestern really gained an incredible notoriety for their results and their 4-day kidney transplant discharges and 2-day kidney discharge. But the reality is they were walking across this bridge to a home hospital, which was very much an inpatient suite. And it was very much exactly as Tom has outlined. They had patient visits, they had, nurses that showed up with medications and so on. And many of us in transplantation, our transplant patients are sick, and we always talk about how challenging they are physiologically. But the interesting thing is that notion really pushed the envelope for everybody. And I think sometimes we don't get as carried away. We do get carried away with money. I'm not going to say we don't, Eric, but there's transplantation really is almost a perfect socialized medicine type perspective because the organs are federally allocated. Medicare actually requires the burden for a lot of things. And then there's a lot of reimbursement downstream from the Medicare cost report and an organ allocation cost. So the hospitals are always happy. But physiologically, the thing that I've always been struck by is you ultimately end up realizing that many patients really can't be discharged home in 4 days. And I think that the thing that we're learning now is how many patients were really getting home physiologically, realistically, within 24 hours of surgery, which I would say, when I started out as a intern in the 90s, it was unbelievable. It was unfathomable, right? We brought people in for a bowel prep for colon surgery. And so I would say that I think this work is, going to be landmark. Other people are doing it, but I think you guys are to be commended for the push that you have. And I think sadly, one of the biggest challenges is going to be how do we deal with the patients that have less health literacy and are in many ways underserved from a healthcare perspective. And I would actually say that potentially this opens the door for us to take a little more stock in their care and the things that they need. But once again, I'd like to thank the group for their work, Eric for his contributions, and unless somebody has some pressing questions or issues or final comments, I would once again like to thank you all for your participation and let you back to your families.
Thanks, everyone.
Thanks very much.
Thanks so much.
Thanks, everyone.
Everyone, thank you, Carlos, for organizing.
Good to see everybody.
Carlos, great job.
Thank
Thank
you,
you so much
Eric.
for including us.
Thank you.